our invited guests here present, other distinguished members of the audience, first, I welcome you to the 121st Inaugural election. On this note, I want to invite the Registrar of Olabisi Onabanjo, Dr. Caleb Ilimubayo, to please step forward and invite our amiable Chancellor, the intellectual entrepreneur in this university, Professor Ayodi Agbola, to please step forward and declare the 121st Inaugural lecture. Doctor.
Thank you. Your Excellencies, Your Royal Highnesses, my Lord Spiritual and Temporal, gentlemen of the press, distinguished ladies and gentlemen, I welcome you all to the 121st Inaugural lecture. It is my pleasure to invite the Vice Chancellor, Professor Ayodi, to declare this 121st Inaugural lecture.
The principal of the university, provost, deans, head of department, now present, other members of Senate, we are fathers, invited guests, the celebrant and the family, their present, and my dear students. On behalf of the Senate of this great university, I hereby declare 121st Inaugural Lecture open.
Discipline, ladies and gentlemen, this 121st Inaugural lecture is a deliberate by no other person, by Professor Tamramat Iyabo Runsewe-Abiodun, we are here to Vice Chancellor to introduce the best lecturer of the day.
We have asked the celebrant of today to read slides and main sermon. It is my pleasure on behalf of Senate of this university to introduce to us Professor Tamramat Iyabo Runsewe-Abiodun. She was born on 26 September 1955, and she had a primary school education at the Asarudin Primary School, Alakoro, Lagos, from 1961 to 1967. And from 1968 to 1972, the young Iyabo was at the New Era Girls Secondary School, through Lagos, where she married the head girl of the school in 1972. The same year, she was declared the best students, academics, and moral. While in the school, she was the commandant of the Nigerian Red Cross Society and president of the Literary and Debating Society. Not surprised, she rounded up her stay in that school with a grade 1 distinction. She had her HSC at the popular school in Ijebu, Adiola Odutola College in Ijebu between 1973 and 1974. And she led a track in the Sign of Time as the Speaker of the school's Legislative Council and the Dining Hall Committee. In pursuit of the golden fleece, she left Nigeria in 1975 for Cairo, Egypt, where she studied medicine under the scholarship of the Hussein government and backed NBCB, Cairo. Upon her return to Nigeria in 1982, she had an internship and later NYC at the Baptist Hospital of Onabanjo. And thereafter, she took up a position as a medical officer at the State Hospital in Aba from 1984 to 1986. From where she transferred her service to the Ogun State University Teaching Hospital, now known as Olabisi Onabanjo Teaching Hospital, as the first appointed registrar in the hospital. In the Department of Pediatrics, in OMTH, you rode through the ranks, become a consultant pediatrician in 1997, having obtained a fellowship from West African College of Physicians. She joined the services of the Ogun State University, now Olabisi Onabanjo University, in 1997 as Lecturer 1, and through the rate of hard work, rose to the position of a professor in the year 2020. This resourceful scholar has for almost 3 decades contributed significantly to the development of the university, apart from teaching pediatric nutrition, community and social pediatrics to undergraduates. She has also served in various administrative capacities, including the acting head of the Department of Pediatrics between August 2018 to July 2020, Chairman Faculty Ceremonial Committee, Chairman Medical Graduate Induction Committee, and Chairman Faculty of Clinical Science Colloquium Committee. She has had, at one time or the other, been the environmental officer and member of the Health Committee, to mention a few. Prof Runsewe-Abiodun was opportune to travel around the geopolitical zones of Nigeria and determining the need assessment for provision of the integral management of childhood illness as at the arrowhead of child survival strategy in Nigeria, and eventually being one of the trainers of all areas of health workers in Nigeria, Ghana, Gambia, Sierra Leone, on the implementation of that activity. She had a working experience in the humanitarian services by serving as consultant pediatrician and nutritionist in Sierra Leone immediately after the armed conflict in that country in 2003. She later worked as temporary technical advisor to WHO, Gambia, and Sierra Leone countries, supporting provisions of quality child health in those countries. She was also a consultant pediatrician with UNEPA and UNICEF Sierra Leone country office from 2009 to 2013. She was the clinical director for a UK-based NGO and consultant pediatrician to UK international agencies in Sierra Leone. She has also made a mark as the only consultant pediatrician in public service in Sierra Leone between the year 2009 and 2012. She started postgraduate training in pediatrics in that country. And this resulted in the production of 6 registrars in pediatrics, temporary accreditation for pediatricians by the West African College of Physicians, and recognition of Sierra Leone as the examination center by the same body. She also commenced and socialized pediatric nursing training in the country and mobilized resources for the establishment of pediatric department and a special care body unit that worth nothing less than $300 to $500 US. She was also a visiting lecturer to head of the Department of Pediatrics, College of Medicine and Other Health Sciences, University of Sierra Leone, between January 2011 to August 2013. In Europe, she was appointed a visiting lecturer in pediatrics at Otto von University Baden-Württemberg in Germany between the year 2007 and 2008, where she taught tropical pediatrics and engaged in several collaborative research efforts in malaria. As a prolific writer and academic by excellence, Prof Runsewe-Abiodun had more than 55 publications in the academic life. As a technical lead, she has written nothing less than 40 technical reports to various international organizations, including WHO, UNICEF, FAO, NHI, NSA, and so forth. As a medical practitioner, she has served the hospital and a professional body NMA in various capacities. The hospital benefited from her numerous services and the chairperson of the Christ Committee from the year 1993 to the year 2020 for the lifespan. She was a 2-time treasurer of Ogun State NMA and consequently the vice chairman of our SIM association. Our inaugural lecturer of today was a member of the WHO Expert Committee on Persistent Diarrhea and one of those who adopted training materials for malaria in Nigeria. She has participated in capacity building of various areas of health workers within and outside Nigeria, where she served as the team leader, first director, or clinical director. She is a recipient of several awards, among which are Ogun State Undergraduate Scholarship for Overseas Medical Schools between 1976 to November 1981, source of Ogun State government, honorary Rotarian Award for exceptional service in promotion of child health in the Jebu land, a certificate of merit strengthening the Sierra Leone Nigerian relationship in areas of child health and education. Professor Runsewe-Abiodun is a member of several professional bodies, including Nigeria Medical Association, Medical and Data Consultant Association of Nigeria, Pediatrics Association of Nigeria, and Association for Good Clinical Practice of Nigeria to mention of the field. Ladies and gentlemen, Prof is happily married and blessed with lovely children. In addition to this, Prof will be the first professor that, when he is eventually retired, will have a permanent legacy in her name. Yesterday, we did a foundation name ceremony in her name, being donated to this university by the children. Please join me in welcoming Professor Tamramat Iyabo Runsewe-Abiodun to the podium to give 121st Inaugural Lecture on this university. So pardon me for my excesses. You happen to be my lecturer, so I need to know that. Can you not see that?
Other principal officers in the university, distinguished members of the postgraduate school, the other colleges, and deans of faculties, colleagues and friends from sister universities and institutions, your Royal Highnesses, my Lord spiritual and temporal, great students of Olabisi Onabanjo University, great Ola, my friends worldwide, gentlemen of the press, distinguished ladies and gentlemen. Talking about how I come to study medicine and later specializing in pediatrics. Did I choose to study medicine from the outset? No. I just happened to be in charge of necessity. I was forced into medicine at Providence, meant to stay in children's world by force of my National Youth Service Corps. Posted to children's world in State Hospital Iyabo by force. Went to Olabisi Onabanjo, the State University Hospital, Shagamu, at inception as pediatric registrar by force. I was forced to pick a topic in nutrition by late Professor Adimola Akinsobo. He picked on a diet that, although eating in an environment has been minimally worked upon in the area for me to work on, the African breadfruits are for. It's a nutrition diet for children with mild to moderate malnutrition. To a very large extent, these were children in ordinary health and would not present in the hospital as they were deemed healthy. That, in essence, meant I had to go into the community to look for them. Hence, I became a pediatric nutritionist in the community by force. I am grateful to all the people who forced me along, preparatory to my adventure in the belief that our children will survive. I stand before you this afternoon on the shoulders of those who are graced this podium in my department, the Department of Pediatrics, Professor Akesode, Olani, Olariwaju, Olu, Ogunesi, and Edgar. I salute the memories of four of my predecessors and mentors, late Professor Ati Adimola Akesode, late Professor Olani Ayola, late Professor Adetunji Adeyekunu, and late Professor Emeritus Hamilton, who have contributed most immensely in shaping who I am today in the academia. As I bring to you the 7th inaugural lecture in the Department of Pediatrics and the Faculty of Clinical Sciences, and the 121st in the university, nurturing the African child in the community, the pediatrician of elders Olabisi. To see the background, the term pediatrics is derived from the two Greek words, by meaning child and meaning doctor and healer. As such, the word is intended to mean healer of children. A child is defined as any person from newborn up to 18 years of age, according to the Convention on the Rights of the Child. Pediatrics is therefore the art of medicine that deals with health and well-being of children up to the period of innocence. Until the late 18th century, pediatrics was essentially a part of internal medicine, and in some parts of Europe, pediatrics is still being restricted and seen as a specialized form of medicine, whose rudiments are not taught until post-graduation from the medical school. In Africa, however, pediatrics is taught at all of the 5 clinical sciences courses at the private level in our medical schools. Pediatrics ordinarily makes the specialist and advocate for children in health and in disease, especially in their areas of interest. Community pediatrics is a subspecialty that emerged sometime around 1890. While Professor Abraham Jacobi is mentioned as the father of community pediatrics in the United States of America, we have the likes of late Professor Keitalam, late Professor Professor Adinka Great, and so on, being pioneers in Nigeria. Community pediatrics is a recognition that family, educational, social, cultural, spiritual, economic, environmental, and political forces act favorably or unfavorably, but always significantly on the health and functioning of children. It is a synthesis of clinical practice and public health principles directed toward providing healthcare to a given child and promoting the health of all children within the context of the family, school, and the community. Community pediatrics is a perspective that enlarges the pediatric focus from one child to all children in the community, one child being seen as part of the entire community. It is to advocate especially for those who lack access to care because of social, cultural, geographic, economic conditions of special healthcare needs. Hence, community pediatrics in the tropics and subtropics looks at problems facing the child and the solutions to the problems as they relate to him or her in the community. In the sub-region, major contributors to morbidity in children under 5 are prematurity, rare respiratory infections, systemic pneumonia, bacteria, malaria, diarrhea diseases, congenital malformations, injuries, and infections, UNIGM 2023. This is in spite of the numerous advancements in medicine. These findings are in consonance with our findings in our health facility, INA 2012. We concluded that these conditions are preventable as they are related to family and social situations. Malnourished children, particularly those with severe malnutrition, have the higher risk of death from common childhood illnesses such as diarrhea, pneumonia, and malaria. Alone or in combination with these illnesses, malnutrition constitutes 45% of deaths in children below the age of 5 years compared to 2020. The majority of childhood illnesses, close to 70%, for which they eventually spawn, have a background within the community, and they can therefore be easily prevented at low levels using simple, evidence-based measures such as access to basic life-saving interventions like stable delivery and birth, postnatal care, breastfeeding and adequate nutrition, vaccinations, and treatment of common childhood diseases. So, taking a child as an option to the community helps in the management of his or her with results in lower morbidity and mortality. As a community pediatrician, I therefore bring to you the outcome of my long adventure policy through first-hand activities in communities and through research works also in the communities with the intent to nurture the people clinical care, feeding and being their advocates. These being the essence of nurturing. An enumeration of contributing factors to illness and so-called social determinants can save many young lives in sub-Saharan Africa. Child survival in the sub-region. In the course of my journey, I recognize certain factors as being largely contributory to child survival, such as delay in presentation for minor ailment, which is available in 2011, poverty, which is available in 2002, poor political will and commitment, which is available in 2001, teen pregnancy, ignorance, low female education, which is available in 2013, and aftermath of conflicts, which is available in 2008. The preferred source of data is a single registration system that records births and deaths on a continuous basis, collects information as events occur, and covers the entire population. However, the outcome of my visits to hospitals within Nigeria and some other African countries reveals that they were without viable or fully functional vital registration systems that accurately record all births and deaths, which is the available Osun State 1998A, which is the available Lagos State 1998B, which is available to the 2020. So, for purposes of this inaugural lecture, I will be relying on figures from sources such as surveys of international agencies. Between 2000 and 2022, the world lost 221 million children, adolescents, and youths. That is nearly the entire population of Nigeria, the world's sixth largest country by population, or population prospects 2024. Children younger than 5 comprise 162 million of these lives lost, almost equal to the population of Bangladesh, the world's eighth most populous country. Initial deaths accounted for 72 million, 2.6% of those under 5 deaths, 1 million, 41.2% deaths occurred among children aged 1 to 59 months, IGN 2023. Global trend in undefined mortality rates. However, it is important to note that the global undefined mortality rate, that is the probability of a child born with a severe ability, died with 5,000 lifetimes and declined significantly between 1960 and 2022. Since 2000, the global undefined mortality rate has declined by more than half. In 2022, annual undefined deaths dropped from 6.5 million per 1,000 lifetimes to 4.9 million. Of the 4.9 million undefined deaths in 2022, 2.3 million, 6.94% occurred during the first month of life, and 2.6 million, 3.06 children died between the ages of 1 and 59 months. The lives of an additional 2.4 million children, adolescents, and youths ages 5 to 24 years old tragically short that year. The decline was mainly attributable to several factors, as contained in the United Nations Children's Fund document of 2024. These are sustained commitment by governments, developmental partners, both local and international, healthcare workers, professional groups, and families. In spite of these global remarkable achievements, the annual death toll among youths, infants, and children, youths, and adolescents remains unacceptably high in the sub-region. While the global undefined mortality rate fell to 37 deaths per 1,000 lifetimes in 2022, children in sub-Saharan Africa continue to have the highest mortality in the world at 71 deaths per 1,000 lifetimes. This is 14 times higher than the risk of children in Europe and North America, implying that a whole lot more needs to be done in order that the Sustainable Development Goals, SDG, will be achieved in the sub-region. Child health and Sustainable Development Goals. The Sustainable Development Goals adopted by the United Nations in 2015 were developed to promote healthy lives and well-being for all children. It has 17 global goals that address the social, economic, and environmental dimensions of sustainable development. Attached to these goals are 169 concrete targets measured by 232 specific indicators, 45 of which are child-related and concern the overall development. The SDG 3.2.4 is to end preventable deaths of newborn and infant children by 2030, with the following specific two targets. One, to reduce newborn mortality to at least as low as 12 per thousand lives in every country, and two, to reduce all-of-life mortality to at least as low as 25 per thousand lives in every country. In a noteworthy achievement on the journey to eliminate all preventable challenges, the annual number of people on the planet that declined by 1.5 in 2022. While the decline in other mortality rates is to be noted, the tragic loss of nearly 5 million children younger than 5 in 2022 was not be forgotten or overlooked. These global undefined deaths were primarily concentrated in two regions: Sub-Saharan Africa, 87%, and Southern Asia, 26%. Even with the decline in undefined deaths, as deaths within the first 28 years of life, account for 33% of deaths in children in youth age. When children are born into the poorest household or a fragile and conflict-affected setting, their chances of survival are immense. IGN in 2023. Child health inequity, therefore, continues to pose a great challenge to survival of children less than 5 years in the tropics. Poverty, low education of the mother, wealth content in the family, fragility and conflict affectation of communities. The undefined mortality rate of children living in fragile and conflict-affected situations is nearly triple, that is at 73 per thousand lives. The risk of all countries not classified as states at 26 per thousand lives, and almost twice the rate of all new and middle countries. Then, the global rates of child mortality are declining. These averages mask persistent and entrenched inequities among vulnerable populations of children. Hence, attaining the SDG for child health in sub-Saharan Africa will therefore appear like a mirage unless quick actions are taken to connect the identified factors mitigating against child health in the sub-region. Mortality among 1 to 59 months old is generally more responsive to basic public health interventions, while the later mortality rate relates more to complications around the time of birth, and prevention activities are therefore more towards safe motherhood. These knowledge and interventions are available, and greater investments will be made at local, national, and global levels to deliver these solutions to every child in every corner of the globe. Nigeria and SDG progress. Based on the 2022 UNICEF data, of the 45 child-related SDG indicators, Nigeria is on target for only one. That is prevalence of overweight among children over 5 being less than 2%. Trend in over 5 mortality rate in Nigeria. Nigeria seems to be making some progress in reducing over 5 mortality rate, albeit too slowly, as you can see on the slide. In 2020, Nigeria was listed as one of the top 10 countries with the highest number of deaths and also among the 39 fragile conflict-affected sectors by 1 point. Trends in early childhood mortality rates. Recent reports of the Nigeria Demographic and Health Survey 2023-2024, as released by the Federal Ministry of Health, indicates that Nigeria's child health indicators have only marginally declined in the last 5 years, with the undefined mortality rate declining per thousand lives from 132 to 110, and infant mortality rate from 67 to 63, while the later mortality rate increased from 39 to 41. I think reading this makes me feel like I need a seat We are looking at the trend in early child mortality rates, and we have a recent report of the Nigerian Demographic and Health Survey 2023 to 2024 at Univ by the Federal Ministry of Health, Nigerian child health indicators both marginally declined in the last 5 years. With the non-prime mortality rate declining, 1,000 life births from 132 to 110, and the infant mortality rate from 67 to 63, while the neonatal mortality rate increased from 39 to 40. In the same report, activities geared towards child survival in Nigeria and breastfeeding and vaccination are either stagnant or have plummeted in the last 5 years. 41% of children aged 6 to 23 months were fed a sweet beverage, and 24% of the same children consumed underlying foods during the previous day. They were against the attainment of nutritional food and the needs of dental care in children. Trend in exclusive breastfeeding reveals that the number of children who receive only breastfeeding drink of food, known as exclusive breastfeeding, up to the age of 6 months of life stagnated at 29%. For childhood vaccinations, although the number of children between 1 and 2 years olds who received full vaccinations increased from 31 to 39%, the number of children of same age who never received any dose of vaccination in Nigeria increased in the last 5 years from 19% to 31%. For child growth measures, the nutritional status of children under 5 has also not improved in the last 5 years. In 2018, 37% of children under 5 were stunted, 7% were wasted, 22% were and 3% were overweight, as compared with 40%, 8%, 27%, and 1% respectively in the 2023-2024 NHS report. Child survival in Nigeria. Hence, in the tropics, children are affected by medical and social-cultural conditions, poverty, ignorance, insecurity, conflicts, attacks for lack of political will and commitment, poor network, no paid education, and medical conditions earlier mentioned are all implicated in the unacceptable high mortality rate in the sub-region, and Nigeria is not an exception. All these are found and documented in our policy and earlier mentioned in technical reports and journal publications. The Nigerian health system. The Nigerian health system is currently bedeviled with a massive exodus of healthcare workers. It is commonly referred to as the Japan syndrome. In 2023 alone, the report of the Federal Ministry of Health revealed that 3,122 doctors exited the system, with 2,130 of them relocating to Europe, Ghana 2024. That the World Health Organization revealed that for every 10,000 persons in Nigeria, there are 4 doctors available to treat or attend to them, giving us a doctor-patient ratio of 4 to 2,500, as against the global recommendations of 1 to 600, WHO 2024. The WHO estimates that at least 2.5 million staff, consisting of physicians, nurses, and midwives, 1,000 people are needed to provide adequate coverage with primary care intervention during 2006. This is a characteristic of the situation in Nigeria. The needed from their doses and treatment really needed. Instead, the high qualified mortality will be unattainable unless efforts are directed towards ensuring that health workers stay back in the country through appropriate remuneration, secure working environment, and safety for life and property. Integrated management of childhood illness, INCI, in Nigeria. The National Council on Health in 1997 ratified the implementation of the integrated management of childhood illness, INCI approach as the main thrust of its strategy. I was privileged to be among the 12 participants at the first INCI demonstration training in Nigeria in May 1998. This was to develop the inception of INCI in Nigeria. This training marked the beginning of my foray into community pediatrics activities. It was clear that if children in sub-Saharan Africa are going to be saved, pediatricians need to go into the communities. And so began my journey into the 32 out of the 36 states in Nigeria, and then Ghana, the Gambia, and Sierra Leone. The outcome of my adventure within the communities is documented in over 20 technical reports to United Nations and multilateral organizations. These also form a part of the compiled report by the Child Health Department of the Federal Ministry of Health. As a part of the implementation of the early phase of the INCI approach, I was involved in trips to determine the next acceptance of the early insight. Trainings either at course or through the director, or being simply a facilitator of different cadence of conduct. This informed to my essence my research interests as I struggled to either provide solutions to identify gaps or document health challenges affecting children in Nigeria and Africa. Although my interest in community pediatrics was one of my activities during my research work on my fellowship on children with malnutrition, the interest was further fueled as I moved around communities and countries on several of my mission trips with a number of United Nations agencies and multinational organizations aimed at improving childhood. Concerning the INCI strategy, although there was some political will, we realized that the political commitment was lacking. For example, whereas partners supported the early implementation of INCI in Nigeria to the tune of $600,000, getting the local government to buy into the strategy during the expansion phase was met with reluctance. As training facilitators, we sometimes had to resort to struggles and real administrative manipulations to even conduct trainings, as stipulated by WHO Submission of 2000. Studies have shown that capacity building of health staff is non-negotiable if mobility and mortality of children 2011. I identified social determinants of child health in the sub-region and documented the following major technical reports agencies. high attrition rates of public workers and training results, inappropriate selection of workers in trade and which we are going to achieve, insincerity of public workers abandon their duty posts, and use full chain equipment provided by partners for their personal use, such that vaccines that are fairly degraded while used even during national election days, which we are building in 2012. Also, that poor and dangerous road network, poor or outright misuse of basic infrastructure in the health facilities that I will demonstrate in the next slides. Food, flat, mineral drinks, and bottles of water and vaccines that release, poor network, poor infrastructure in health facilities. My contributions to China community foundations. In my journey as a nutritionist in community nutrition, I had the opportunity to work with all the 6 million in Nigeria involved in meat assessment and active surveillance for anti-plastic paralysis, training different figures of health workers in Nigeria, Ghana, Nigeria, Senegal, Kenya, and ICI, severe malaria and diarrhea disease and nutrition. In that post-director, clinical instructor, or facilitator of the United Nations Agency, and so on. In my desire to ensure children with some survive, I also had the opportunity to work with CNO on a South-South collaboration, offering health services to children in the epicenter of the post-conflict region. I also worked in Ghana, Gambia, working with international British organizations such as the and working as consultant nutritionists, and temporary organization. Within the Kenema government house in CNA, between October and December 2002, deaths among the admitted 1.5 million were reduced from 70% to 40% of the total admissions through appropriate diagnosis, treatment, and capacity building of health workers. Still within the sub-region, I conducted the first ever NCI training in Gambia and followed up the training and facilitating to ensure continuity and sustainability of the training. While in Gambia, I engaged in massive advocacy through engagements with the Minister of Health and other top echelons of health in the university in the country. During the period of my sabbatical leave in 2009-2010, I opted to return to CLU in my mitigation efforts in the reduction of child mortality, as the country at that time had the worst mortality in the world. As a consultant practitioner in an NGO world, and later a director of the Liberian Children's Hospital, the only children's hospital in the country at that time. I was the only consultant pediatrician in the public service in the country, serving the hospital and the rest of CNA for almost 3 years. In that capacity, I was heavily supported by a retired pediatrician who came to support my efforts in the country. Practice, late Professor Named Sofanet, was an epitome of humanity, integrity, and self-respect. A passionate pediatrician. My academic and professional tutelage under him were immeasurable. May so continue to rest. Moving from WebOD and at the invitation of the government of CNO, I requested for leave of absence without pay from the university to offer further assistance to the people and government of CNO. During that time, amongst other activities, I was able to gather first-hand experience and provide solutions to various socio-economic factors that limited the digital survival in that country, which I have earlier mentioned. Their contributions to China, nutrition. Addressing my area of specialty, we demonstrated that the nutritional quality of the widely grown food, African breadfruit, to clear American identity, developing known as among the rebels, Okwa among the Greeks, and Army among the Ghanaians, whose first food had a protein content of 17.9% to be improved through germination. Adebawo et al., 1997. Going further, in a study that spanned 4 communities and involved 150 children, we were able to successfully use apple for the nutritional rehabilitation of children with mild to moderate malnutrition. The study also reveals that the diet was a better grade diet when compared with others in these communities. We use the apple. In a 2-year-old child with moderate malnutrition, that you can see on the slide above, and 12 weeks later, you can see the same child. This study contributed to the listing of the African breadfruit as one of the complementary foods in South Nigeria in the National Policy of Food and Nutrition. In a bid to improve the infant and young child nutrition in resource-consented level, we replicated the traditional methods of preparation of these well-known diets and evaluated the nutrient and anti-nutrient properties therein. This study was unique in that it was the very first to evaluate the nutrients of the diet as prepared locally. The study confirmed that the traditional methods of preparation of the African breadfruit retained the higher nutrient and lower levels of anti-nutrient, which is available and new and new in 2018, thereby providing a viable alternative for the nutrition of our infants and young children. Still on nutrition, in addition to the high prevalence of undernutrition of the 64% that was earlier established in the semi-urban community, which is in 2026, a decade later, we raised the fact that overweight and obesity, which were either too rare in those communities, was becoming an emerging disease, and in the issue at all, 2008. Another decade later, we demonstrated the high prevalence of overnutrition, 6.4%, coexisting with undernutrition of 46.9% among pupils in primary schools within the communities, which is available until 2018, thereby establishing the issue of confronting children in the semi-urban area in southwest Nigeria. We have found that overnutrition was more frequent among children whose parents had university education and were middle-level civil servants. Our study was one of the very few studies from the sub-region that measured the poor physical activity GPA as a contributor to malnutrition and determined that there was a generally low physical activity and poor food frequency score in 96.3%, 87.5% respectively among people who have reached reduced pupils. This, while in addition to poor early infant feeding practices and poor quality of diet being contributing factors to overnutrition among the children, which is available in 2015. At the regional level, while assessing the infant and young child feeding practices among children in the Queen's area in Greater City, we established that the mini diets consisted mainly of chili-based breads and pre-packed formula of our poor quality. They impinge negatively on the nutritional outcome of children, which is available in 2016. This was also found in Nigeria, in addition to the fact that the poor infant feeding practices also have significant association with low level interrogation of the mother and the poor interpersonal practices, which we are going to 2018. We also documented the fact that even among infants exposed to human immunodeficiency environments, overnutrition does occur, and this was often found among those from high socioeconomic class and those who are exclusively breastfed who were at 2017. On the various factors known to contribute to malnutrition in the sub-region, hereditary infestation, especially with ascaris pulmonalis, have been documented to work. In the series, we documented that 51.3% of the preschoolers had one helmet of the other, and that 74.4% of cases of those children who are positive for the hereditary infestation were malnourished. A significant correlation was established between the hereditary infestation and the nutritional symptoms of preschoolers within the rural community, which were available in the book 2008. This hereditary infestation, ascaris and newborn, were found even in children less than 2 years old in that study. So, in order to improve the nutritional symptoms of children less than 5 years, therefore, this work became one of the reference points in determining the commencement of the children less than 2 years. 2. Child survival. As I progressed in academic career, I realized that the overall children lives with fidelity in the community hence my academic bias shifted into pediatrics. In the process of gathering data for research in the community, I encountered significant intrigues, which I documented in the review article as challenges in obtaining informed consents, cultural assistance, and implementation to interview modern collection of public need, cultural beliefs, taboos, and financial inclusion, which is available to everyone. The review article subsequently became a reference point to guide for other researchers in community-based research. 3. Malaria. Malaria is the number one cause of hospital visits in children left activities in sub-region, and one of the 6 major causes of death in children below the 5 years outside the winter period. Although the winter death was more than 40% of deaths in children below the 5 years, malaria was reported with their disease in units. However, in studies conducted in our health community, we showed that both congenital and many told from repeats and winter malaria, which we are doing, were not as uncommon as earlier thought, as we reported prevalence rates of 17.4% and 24.2% respectively in representative studies. Further prospective studies, however, revealed that the long-term signaling of congenital malaria infestation did not necessarily translate to an eventual disease shortening of which we are doing. These studies informed and established the basis for routine screening of for malaria newborns as part of the winter septicemia. Caregivers usually give some form of care to children with fever, a symptom majority of children suffering from malaria. We documented the fact that 79.5% of children with fever receive no form of treatment at all before coming to a health facility, which is being removed from the environment. The majority being used of chloroquine in 23% of cases, in spite of the travel being withdrawn as an anti-malaria drug in the country. Poverty and inability to recognize the benefits of illness were some of the major reasons for this phenomenon. We followed this discovery for the documentation of markers of clinical existence if SCRT 76 in the study population and the possibility of an early emerging resistance to penicillin combination therapy, considering the close similarity between the chemical compositions of the two anti-malaria drugs, initially at 2011. We concluded that there was therefore a need for proper diagnosis of malaria at the point, since malaria is the most common suspected diagnosis in children with fever, so that abuse of ACT and development of resistance to it can be prevented. In order to actualize this, we documented that malaria rapid diagnosis test kits compare favorably with the gold standard the diagnosis of malaria, which we are available in 2012, except as we have also found in units made in 2007. Hence, we recommended the routine use of the malaria rapid diagnosis test kit at the home front. In terms of malaria control, Nigeria adopted the Abuja target of increasing proportion of people living under insecticide treatment ICO to 16% by 2005. This, of course, was not achieved, or that's why we are pushing the should collapse on the kids. We documented poor promotion of its use among the public, particularly by the health workers because of their inadequate knowledge and ICO. We are no longer evaluation of monitoring by kids. These your findings have resulted in poor utilization within the communities. We confirm this when we demonstrated that professional practices and others and used by the vulnerable groups that is mothers and children were known in the state, which is the Abiodun and which is 2013, which is the Abiodun and the 2013. Malaria is known to have very deleterious effects, especially in the vulnerable group. Pregnant women, children below the age of 5 and non-living infants. Malaria in pregnancy has often resulted in delivery of low-birth babies. It all constitutes a great percentage in terms of neonatal mortality. Considering the huge number of pregnant women who patronize non-orthodox practitioners. We studied the practice of traditional birth attendants with regard to the treatment of malaria in pregnancy. Our finding revealed that chloroquine was still very much in use, even among that group 10 years after Nigeria had implemented the change in the national policy in treatment of malaria. We therefore recommended that government made an institute capacity building in this group, especially in forestall the development of malaria and resistant community, like the children's community. 4. Community pediatrics. As quantitative studies began to gain grounds and reputable tools for getting the help of communities and in providing the work for the we conducted several of these related with the intention of generating the same gaps in community studies and solutions. Quantitative studies of strabismus are uncommon within the subregion, and there are very few in comparative literatures. We documented that there was a negative perception and acceptance of people with strabismus, such that the stigma attached to the condition interfered with access to healthcare services for being treatable condition following until 2016. Although teen pregnancy has been studied extensively within and outside the subregion, we conducted a focus group discussion where teenagers were involved. The uniqueness of the study was in the fact that, unlike other studies, non-pregnant teenagers were the subject. The study identified a hitherto unidentified factor, such as lack of motivation in the girl child, as an underlying contributory factor in the incidence of teen pregnancy. This has never been mentioned in other similar studies. The study thereby bridged the gap in the gap of quantitative studies on the incidence of teen pregnancy, female empowerment, government support for girl child education, and appropriate rewards for moral and academic excellence were recommended to ensure the girl child remained focused, pushing the Abiodun and the more in 2020. Foodborne diseases remain a public health issue in developing countries, and outbreaks often result in devastating health outcomes. At the time Lassa fever was ravaging the land, we documented a huge gap from food safety and hygiene, foodborne and infectious diseases, which we are able to see. The dissemination of the outcome of this study led to massive health education campaign among the general population and training of food handlers. Sometimes, long-term diseases in children are often as a result of late identification and poor treatment. Using a immune dipstick, we confirmed that asymptomatic bacterial and viral tract infection are not rare among the average intelligent school group, alleging Abiodun and Olabisi 2019. Hence, we advocated that if chronic kidney disease is to be reduced, then early detection and treatment of urinary tract infection was be addressed in the school health screening program. Challenges. It is not likely that anyone that embarks on trips like mine will have it without encountering hiccups and challenges of the week. Were there challenges? Yes, yes, and yes. The major challenge as a community pediatrician is mainly in the area of the level of understanding of this discipline within the tertiary environment. As seen in the narratives, if there is going to be any reduction in the high child mortality rate, especially in the tropics, the contributory factors to the evolution of the disease must be addressed. Knowledge of these facts is not within the walls of the hospital. They are in the community. Hence, it is without being said that community pediatrics have a training component and both training centers have to show more commitment in ensuring that the trainers and the trainees get exposure and experience within the communities. In essence, availability and session outside the meeting catch by people, though essential for training their risks and commitment, is paramount to successful community pediatric training and practice. Solutions. Globally, unless urgent action is taken to end preventable newborn and child deaths, Nigeria, like many low-income and low-income countries, will not meet the sustainable development goal targeted for newborn and infant. About 35 million children under the age of 5 died before 2020. Majority of them come from families in sub-Saharan Africa, Southern Asia, from low or middle income and lower middle income families. If, however, every country realized the LTD vision of an end to preventable unemployment and met the relevant mortality targets on time, 9 million more children will survive to the age of 5. Yet, today's scenario is first for alarm. On the current trend, there are 49 countries that will meet the LTD mortality target, and even more, 64 countries will meet the mortality target. In 2020, approaching quickly, progress will be prioritized and accelerated to ensure every newborn and child life survival is kept. Number 2, urgent action needs to be in place to redress the DAPA syndrome, as earlier highlighted. Number 3, pediatricians have to identify with the community in order to experience firsthand the children in ordinary health and illness. That remains the only way to successful. Number 4, academics will be encouraged to contribute vigorously capacity building and to put in more efforts in activities to contribute to the nation by ensuring such activities count in their appraisal. Number 5, according to the WHO, member states like Nigeria need to feed the calls to address equity through universal health coverage so that all children can access essential health services without undue financial hardship. Innovative, multiple, and tailored approaches will require strategic redirection and an optimal mix of community and facility-based care. Number 6, health sector and multi-sectoral efforts will be put in place to reduce inequality and any negative effect on social determinants. I will not address the right country and people down. Not me. As a community pediatrician, I hereby submit that I have been involved in the care of children through clinical activities, mentored all cadre of healthcare workers within the hospital and communities in Africa. I have influenced child nutrition through research works and contribution to nutritional policies. And I have been advocating for children through community engagements at all levels in Southern. In all, I have contributed my own effort in nurturing my culture through my adventure. Patrick, number one thing, you cannot put your car in the back there and expect to reach your goal. Nigeria and indeed Africa need to up their game if the SDGs for childhood are to be achieved by 2030. I will recommend as follows, Mr. Vice President, that training in pediatric nutrition should be more community-oriented. Hence, more funds should be committed to ensuring that medical students get hands-on training in the communities. Also, at the national and regional levels, funding for health generally, including the mental health coverage as well as education, should be increased to global standards, such that the health workforce will be encouraged to jump at them. Mr. Vice Chancellor, it has obviously been a long trip, widely including communities, building capacities and community, undergraduate and postgraduate levels across all the health workforce cadres, and researching into how to eliminate the sufferings of children and adolescents in Southern. Mr. Vice Chancellor, principal officers of the university, it has been an endless policy, what to provide in the long run. However, And the Bible says in Luke 14:22b, there's still room for more. And then again, and follows that thing in pediatrics and job. Acknowledgement. To God Almighty, I return of glory, honor, and adoration, and see me thus far, and granting me this single opportunity to do. I am indebted to the Vice Chancellor, staff, and presence, the University Principal Officer, and management for the opportunity given to me to contribute in our own little ways to improve the health of children within Nigeria and the Southern. To the current Vice Chancellor, Professor Ayodele Olayinka Johnson Awola, and remain grateful for this time to share a tiny bit of the account of my journey, experience, and my modest contribution to the global effort and survival of children, even if it is coming at the twilight of my exit from the university. I acknowledge with deep gratitude everyone who has contributed one way or the other to making me who I am today. I'm grateful to my teachers and mentors as a young medical graduate, Dr. Peter Iyabo, who will take me in pediatrics all through my stay and recover, and thereby make the foundation of my interest in pediatrics. Dr. Shagun Peshito, who granted my skills as a medical officer in the hospital of Abeokuta in the mid-80s. Dr. Adeleke Ibadeajo, who employed me to join the teaching hospital in Shagamu as soon as it was inaugurated in 1986. I appreciate the cooperation of my colleagues in the Federal Republic of Germany, Nigeria, and Nigeria team, who added in no small measure follow to my scholarship. I will not forget my other friends in Milenshine, Taliban, and Little Bulgaria, who will start my events. May the soul of this Benjamin be beloved. Rest in peace. My fellow adventurers in the ICR Nigeria families, I'm grateful. I must however make specific mention of Dr. Oluwatoyin Salawu for the opportunity she gave me to travel to Nigeria, and Dr. Tunde Adebiyega for initiating my consent into the Univ. I hereby express my deep gratitude and appreciation to my co-authors, too numerous to mention, within and outside Nigeria. The experience has been wonderful. I appreciate the contribution of all who have read through and edited this lecture. I appreciate my colleagues, both senior and junior in the Department of Pediatrics, Olabisi University, and the Teaching Hospital. The invaluable non-academic staff members was privileged to work with the department, the faculty, and college. Special mention will be made today of my sister and friend, late Mrs. Olayinka Olaomi, the Abitukuso. Rest in peace. Members of Medical Women's Association of Nigeria with State Branch, members of N1 Senior Members Forum, Nigeria Medical Association of the State, and other groups I belong to. Members of the Community Development Association are grateful for turning up to honor me. I recognize their presence and online members of my NCL family, representatives of my alumni, Mineral Just Secondary School neighbors. Please stand up, we are here. My classmates, the 58 and the 2 years they are dead. Please stand up. Member of the Kickstarting the Reverend, my numerous friends all over the world. I acknowledge the contributions and support of my younger students and my in-laws, their parents, their Vietnamese, their devotees, and the families. I recognize and appreciate the presence of the Excellency Dr. Olatukunba Oluwatoyin Essential, and my brother, my friend, and classmates, like Adebiyega. Please stand up for the information. I deeply appreciate the part played by my sister and friend, the immediate part coaching of this university, Dr. Tamramat Iyabo, my twin sister friend, Mrs. Iyabo, and Ms. Kenny, in the success of the meeting today. I remain indebted to my parents, late Mr. Moshiri Adebo Runsewe-Abiodun of the Onabanjo extended family, and the late Alhaja Sita Iyabo Runsewe-Abiodun of the The neighbor are not being made. I think the source very important. Finally, I think on record, the support and sacrifice of my children. Olùdíje Tèmítọ́pẹ́ and Olúwaṣíṣe to their spouses, Tẹ̀mítọ́lá, Ìfẹ́dọ̀lápọ̀, and Ojúláyọ̀ respectively. To my grandchildren who insisted on being a part of the family, I'm very proud of your decision. My grandchildren is that this month, Olusegun Abiodun, retired permanent secretary in the state. I owe this moment to God Almighty. We have been a numerous emotional leader, support system, partner community. Without whom this movement will never. I appreciate your sacrifice, love, and purpose here. You have been revealing both value process. Thank you. I thank the most sincerely for the presence, your patience, and rapt attention. God bless you.
The blessed nature. I promise that I will not leave this stage until I pronounce your name as a poet. So, sorry for that. It is Professor Tamramat Iyabo Runsewe-Abiodun. No doubt, in the course of the lecture, the guest lecturer has introduced or recognized most of us here, but what remarks that we must recognize in a special way some dignitaries here. It is on this note that I want to recognize former Deputy Governor of the State and the distinguished Senator of the Federal Republic of Nigeria, His Excellency Alhaji Senator Onabanjo. Let us recognize His Royal Majesty, the Alhaji of Onabanjo, represented by the Baba of Onabanjo, Chief Adepewale Sunday of Onabanjo. In a special way, let me also recognize the Grand Chief Imam of Ijebu, represented by the Pioneer and retired University Librarian, Dr. Tafi Sanesu. Let me also recognize Architect Kayode Adebayo, former special advisor to the government on urban and regional planning. And the former chairman, the General Government, the government. Let us recognize the former provost, Chagamo, Professor at ABE, Olabisi. Okay. I'm told that the representatives of Senegal are also here. Can you please stand up for recognition? Okay. Thank you. Very shortly, I will invite the Vice Chancellor to declare this ceremony closed. The procession will go out in reverse order. While the procession goes out, we are expected to write up on this time again. Thank you. Then I invite the Vice Chancellor to declare this ceremony closed this season.
Once again, I recognize the principals of the university, provosts, deans, head of department, members of students present. It has been an interesting day, and I know that everybody will have taken one to the other home on this issue of community reductions. I know that Prof has tried his best to put it down to the level of those that are not immersed be able to understand the language a little bit. So it's not that abstract, but I can see some people judging, some also saying. I want to use the opportunity to thank KBSC that always find time to be here. I want to thank the Deputy Governor, Deputy Governor of the state, other dignitaries, but everybody seated, also important. On behalf of Senate of this university, I hereby declare this inaugural lecture closed.
Thank you very much, our own Chancellor. The hall now rise as we observe the reception of the distinguished personals we are reciting. Thank you very much. For the Vice Chancellor will be giving the reception of the distinguished personals we are reciting media, followed by the inaugural lecturer of today, and the distinguished Professor of Nutrition and Community Pediatrics. We appreciate you. And we put our hands together for them. I will respect the distinguished members of the family of the inaugural lecturer to join the post-secondary reception. Thank you very much. Thank you. Thank you very much. Please join the reception. Happy from the last person. We continue to appreciate them. Thank you. Thank you very much. Thank you very much. So this is I really want to recognize our distinguished provost from our provost of Thank you very much. Thank you very much. The thing is about the appreciate you. You should be very blessed, but thank you.